Koto Katoa, thank you very much for the introduction. And I'm very sorry for not being there in person. Today I'm going to talk about an application of artificial intelligence and machine learning in patient prioritization and pathway allocation, especially created for geriatric cohort. So this project was initially part of my PhD project, supervised by Professor Matthew Parsons, Professor Paul Rouse, Professor Cameron Walker, and Dr. Valery Pavlov. And now I'll try to finish up in 10 minutes. So next page, please. Next slide. Perfect. So we're getting old, and there has been a wide range of opinions about different aspects of healthcare system, and the trends in disability with chronic medical condition and complexities and life expectancy. Also, despite the increase in life expectancy, deterioration in health complexities are inevitable. So healthcare systems should be managing these conditions using optimal intervention. Next page, please. So this is one of the main reasons that geriatric care and management frameworks have been developed and expanded with an ultimate aim of care for older patients in order to meet their long-term care needs and improve and maintain their independence along with their quality of life. Next. And for the same reason, Ministry of Health has released a New Zealand healthy aging strategy. Next, please. One more time, please. But that's not it. So while we're talking about increasing life expectancy and patient complexities, we're also talking about increasing demand on our healthcare systems. So therefore, improving the patient flow and establishing patient flow management within a hospital should become a policy priority to effectively set balance to the mismatch between the unknown and variable amounts of supply and demand, considering limited resources. But the question is, can the current system or the business as usual procedure result in ideal outcomes for all inputs? Next slide, please. It's really tricky. It's a tricky question because in order to answer that, we have to consider various different metrics and measures, which usually falls between concept of effectiveness, efficiency, equity, and value for money, which we know as economy. So we are considering both clinical and operational aspects of patient-centered patient care within this problem, and what gets measured can get managed. So now, one of the primary questions in order to control the patient flow due to the limitation of the resources is how to assign patients to appropriate pathways. So in order to answer that, we basically need to see what does an optimal placement for geriatrics look like and how we can automate this by minimizing resource use. Next, please. So according to the literature, one of the responses to the acute older patient care was the ACE initiative, originally created based on geriatric evaluation and management framework. While they have their differences, all of these initiatives more or less focus on patient-centered care, area rehabilitation, discharge planning, prepared environment, frequent medical review, and multidisciplinary team intervention. Next, please. On the other hand, data-driven modeling potentials has been recognized in geriatric care, where it addresses challenges such as caregiver shortages, resource discrepancies, optimizing the allocation of resources, etc., etc. There is a narrow body of literature that focuses on geriatric care and predictive modeling using machine learning and AI models. On that note, next, please. There is a huge gap within the literature when it comes to developing and applying AI-driven models considering geriatric population, especially when it comes to clinical and operational aspects of geriatric patients. This study is one of the first that created an AI-driven triage and patient prioritization model for geriatric patients, considering factors from geriatric-specific models such as ACE initiatives. Next, please. So in order to address the gaps and answer, we have to answer a couple of questions. And our primary question in order for this research was to answer what is the optimal design of patient flow looks like and how we can sort of assign patients to appropriate pathways. We need to answer two essential questions considering patient journey and not just stage of their journey, such as ward or units. Next, please. So we've created this framework to answer the questions. I will not get into the first two questions today because I'll need a couple of hours to talk about these. So I'll try to basically briefly talk about what we did. So to answer the first question, a systematic literature review and meta-analysis was conducted in order to basically identify the components of geriatric care models and evaluating their effectiveness for the whole patient journey. And the result from the SLR and meta-analysis was showed us that these initiatives have positive results on functional outcome, activity of daily living, mortality, case fatality, discharge destination, readmission, length of stay, and cost. So this was very important to us to see how we can sort of create our model and which measures we should consider for our model for the training process. For the second question, our main purpose was to basically contextualize the problem to New Zealand population and validate the components with senior health professionals. So we did interviews with 11 senior staff at Waikato District and done thematic analysis on the data in order to first validate the optimal components of geriatric care, which was very similar to what we've discussed in the systematic literature review and meta-analysis. And the other thing was to create some sort of a definition for geriatric patient. I don't want to call it a definition though, because we were benchmarking patients to see what sort of cohort we are feeding into the algorithm to train our model. So jumping to the primary research question. Next, please. So talking about the algorithm, about the traffic light system algorithm, the primary purpose of this model was to create a decision support system and triage tool at the point of emergency department, predicting and assigning complex and non-complex patients to their proper complex, non-complex pathway, and doing patient prioritization within those pathways. So we trained the model based on more than 600,000 patient episodes for more than 200,000 patients from 2017 to 2022. And in order to make the model as optimal as possible, we have also considered simulated bed occupancy within the machine learning pipeline. Next, please. So while the main objective variable of the model was whether the patient were in our sort of complex ward at Waikato Hospital, which was OPR 5 ward. These are the variables, decision variables for a model which were selected based on their importance in predicting a complex case, which includes demographics, operational, disease-related, and InterRAI metrics and scale for this algorithm. Next, please. We used a automated machine learning or auto ML model in order to do the model training for the traffic light system. So we used a palette of models from regression to regularized regression decision trees and a variation of these models within their ensembles, so combination of these models. And for the model selection phase, we ran the algorithm for a simulated timeline of 1 year based on actual and simulated occupancies, and then selected the best model based on their optimum performance. So next slide, please. And this is how the very, very initial sort of outcome of the model looks like. So the important bit here for us was the complexity probability. So there are predefined thresholds that was extracted based on the training data to define the complexity groups, which were created based on the complexity probability, and patients are assigned to those groups based on those complexity probabilities. Just an example, here you can see patient number 5, who's complex, PCCL4, with 3 comorbidities, whereas, for example, patient 14 as a non-complex. And for the yellow complexity group, at this point of the development, we suggested that simply clinicians should overview the outcomes and decide what they want to do, whether they want to assign those patients to complex or non-complex pathway. And this should be the main feature. For the future work, we are planning to create some sort of reinforcement learning algorithm to basically refeed clinicians and expert comments onto the algorithm to redefine these thresholds and decrease the number of yellow complexity group as much as possible. Next slide, please. So basically, what we are, our ultimate aim and what is we are currently working on right now is we are trying to create some sort of a simulation model. Can you press next one more and click on that image, please? So we are trying to create a real-time digital twin based on the simulation model, based on what is happening within the system, actual patient flow, and our traffic light system, to be able to create an optimal screening tool to analyze the allocation of older patients to optimal pathway and sort of prioritize them as well. While we are still working on this, we are still working on this digital twin. A static sort of user interface was created for the traffic light system algorithm in Power BI. Next, please. So here in our sort of dashboard, we can have some sort of executive and high-level summary of the data. So at the moment, we are trying to do user acceptability tests and sort of trials on this model in order to make sure all the boxes are ticked before getting this onto production. This is, at this point, this is just a proof of concept. We have to do lots of other stuff before sort of releasing this to the production. So wrapping up, next slide, please. This research will enable decision makers to make more informed choices around the development of patient pathways for older people. For instance, an expansion of like OPR 5 ward in Waikato, which was the complex acute geriatric ward. We can pinpoint the optimal pathway for a given patient considering length of stay, readmission rate, cost, etc., etc. Traffic light system can be an optimal screening tool to analyze the allocation of older patients to appropriate pathways. So next slide, please. And the most important of all, this model can help us prioritize complex patients in order to improve their journey within our healthcare system. We are trying to make sure that we are building a model that could act just as a decision support system, where it was created around clinicians' comments and viewpoints in New Zealand for our geriatric cohort. So that was me. Thank you very much.
We have got time for a question for Abtin. If anyone here has a question or anyone online. No? Anyone in the room? Yes, Sarah.
Thank you for that very fast presentation.
I'm so sorry. I know.
I just wondered if you'd thought about the kind of context around the hospital, for example, aged residential care, because obviously, you know, in some countries that's the bed blocker, and not so much in New Zealand, but obviously it has a huge impact on the throughput through the hospital.
Thank you very much. So that's definitely on our to-do list to consider. At this point, we are just looking at patient input from emergency department to wards. Nothing further. This is just for the project, but on our to-do list, there are like heaps of stuff, including like ARC beds as well. So yeah.